Hey, what's up, everybody? Did you like the new intro? I'm super stoked about that. All right, hey, my name is Sean, and welcome to the broadcast. This is super cool. Hopefully, you've seen some of my other posts, but we are going to be talking, or starting to talk about the new position statements put out by the National Association for EMS Physicians, published in the Prehospital Emergency Care Journal back on the 10th, so a little over a week ago. Um, so really exciting stuff. Real quick, if you don't know me, my name is Sean. You've probably seen me around. I run Flight Crit, and I also run the Medic Lab. So the Medic Lab is our new training group, if you will, our educational, our academy. It's where we're going to be doing most of our live broadcasts and um, live trainings, a whole lot of really cool stuff coming up. Moving on from that, if you are new, or even if you're not new, this is a new broadcast. I can see that we've got a couple people that are watching right now. I would love it if you would just leave me a quick little comment in the comment section. Just say, "Hey, Sean," or "new here," or whatever. Just tell me your name, because there's something else that I really want to show you that's really cool that we're going to be able to do to basically engage you, the viewers, in our broadcast. It's going to be a lot of fun. Um, just put a little comment in the comment section below. You can do it even if you're on your phone or on your computer, whatever. You can do it. I'd love to actually just say hello to you. All right, so I got one Facebook user not logged in, but that's okay because here's what I can do. I can actually put that up on the screen and I can feature your comments. So if you have a question during the broadcast that you want me to kind of share with the group or answer or whatnot, you can go ahead and type in your comment section, and then I can put your question up on the screen and I can answer it. And then that way everybody can see the comment. Whoever just left that, thank you very much. I'm glad to have you here. Thank you very much. So here is what we're going to be doing. We are going to be just starting to touch on some of the new position papers put out by the emergency or the Association for EMS Physicians. Real quick, here we go. That's not the one. That's not the one I wanted. This is the one I wanted. That's not the one. Here's the one I wanted. Still working this out. So, if you have not seen these yet, this is where they are. They are at Taylor and Francis Online. This is the publishing company that puts out the Prehospital Emergency Care Journal. Let me go ahead and pull this down a little bit so you can actually see this. You can just go to this link right here, and I will put that in the comments section below once the broadcast is done. So that you can easily click on it. All of these right now, they are published in this volume 26, issue 1 of the journal, and they are all open source. If you see this little icon right here, that means they are open source. And you can see here there are a bunch of them. I think there are 18 individual papers that the NAEMSP just put out, kind of updating their position statements on pre-hospital airway management. This has been a long time coming, and I think from what I gather, there's actually going to be a lot more of these position papers that they're going to be putting out in the coming years, months to years, looking at all aspects of EMS, not just airway management. But this is where they started, and so this is super cool. So today, we're just going to touch on the first two. The first one is just simply kind of introducing what this whole project is, right? And so basically, if you look at the National Association for EMS Physicians website and you go to their position paper tab, I don't have it up right now. I'm not going to bother to take the time to pull that up right now, but you can actually look at that. You'll see that they haven't done a whole lot for pre-hospital airway management since I think 2007 may have been the last time they put out any position papers on that. So what they did is they basically looked at everything that related to pre-hospital emergency airway management, and they said, what does the best evidence say right now? What is our position, and does it need to update? And clearly it did, right? We know that airway management from a pre-hospital perspective has gone through a lot of changes in the last, almost 15, 20 years. I mean, more and more providers are doing intubation, more and more providers are doing RSI. There's even talk about drug-assisted, non-paralytic intubations. There's bougie-assisted intubations. There's new advances in supraglottic airways, non-invasive ventilation, all the way up. More and more pre-hospital providers are doing surgical airways, and so there's been a lot of change that has come up. And so they said, hold the phone. We've got to do some reevaluation of our guidelines. And so this is kind of that rendition, or this is where this has landed. This has been a project that the NAEMSP has been working on for almost a year now. I think it's about 10 months, and then of course there's time to write up the articles. But this has been about a year in the making, and they looked at everything. And even in their first paper here, the compendium, where they kind of summarize the project, they even say that they missed some topics in here. And so there's going to be some more position papers that are going to be coming out in the very near future that kind of address some more of these. But real quick, let's just kind of scroll through and actually see some of these, right? So they talk about training and education, and we're going to touch on this one a little bit today. And then we're going to have more opportunity in our next broadcast to go into some more depth with some of these other papers. But look at this. They've got pre-hospital airway programs, kind of the quality management portion of that, manual ventilation, use of supraglottic airways, drug-assisted airway management, cardiac arrest airway management, trauma management. I mean, we know that these alone are two huge topics of consideration. So it's really cool to see that they're finally taking a stand and putting out some guidelines on what they expect, or what kind of summarizing the evidence. Excuse me. Optimizing physiology. We know that that has been a really big topic of discussion, right? This resuscitate before you intubate, right? We know that there are a lot of peri-intubation arrests that occur specifically because of the process of intubating somebody, whether we're doing an RSI, drug facilitated intubation, or just putting somebody on positive pressure ventilation. If that person is borderline, tenuous, we know that that it's likely that they will have a cardiac arrest. So how do we optimize their physiology with oxygen, pre-oxygenation, nitrogen washout, fluid bolus, pressure support, all of these things that get a patient ready for airway management. Non-invasive ventilation, mechanical ventilation in the pre-hospital setting. This is huge here in Colorado where I practice. We have a lot of pre-hospital providers or programs that are implementing mechanical ventilation for their transports. It's crazy. It's mind-blowing to me. And we're not talking just inter-facility transfers, but pre-hospital, post-intubation, putting somebody on a ventilator and using that to get them to their destination, whatever hospital they're transporting to. We're hearing this. It surprises me that we hear a lot about that in the metropolitan area where I live, but I don't hear as much of it happening up in the mountains, where you would think more of these programs would want to be utilizing mechanical ventilation for transport. But in any case, surgical airways, pediatrics, they actually touch specifically on pediatric airway management, quality management of pre-hospital pediatric respiratory distress. What else I got here? Respiratory distress and airway management interventions. So lots of really good stuff here. So one thing that I really thought was interesting when I started looking at these position statements is that, for a long time we have really focused on evidence-based medicine. And yes, evidence-based medicine is the hallmark of what should be guiding or driving our practice. Here's the one thing that I thought was really interesting. in the compendium where they talk about the whole project is they talk about down here, second paragraph, each committee made recommendations based upon an evidence-influenced consensus process, balancing available knowledge with expert recommendations when no data were available. So that's kind of a big shift, right? We used to simply say if the evidence doesn't support it, we're not doing it. Back 20 years ago, it was this made sense, so we're going to do this. And now, then the pendulum swung the other way, and we said, well, wait, no, not everything that we do, um, you know, actually, just because it makes sense doesn't necessarily mean that it's best for the patient. Meaning, let's take mechanical ventilation for example, right? In 20 years ago, they'd put people on a ventilator and they would give them 9, 10, 12, 14 mLs per kilo, and we'd get good oxygenation. But then what we discovered is we were actually causing barrel trauma in these patients, volume trauma. We were damaging their lungs because we were over ventilating them. And so now we have the ARDSNet guidelines that kind of tell us that we should be in that 6 to 8 mLs per kilo, and the evidence supports that. But what the National Association for EMS Physicians is, in my opinion, acknowledging that just because there may not be evidence to drive our practice down a certain path doesn't mean that there's not good reason to drive our practice down a certain path. And they're saying if there's no evidence to support this, we're going to fall back on our experts, and we're going to try and improve our practice based on expert opinion, not just anecdotal evidence, but actually say, what do the experts say? How does this look from the perspective of the experts, and utilizing that to help guide our practice. The other thing that they definitely touch on in this is that this is still open for local physician advisor not interpretation, but remember, you practice under your physician advisor's protocols or guidelines, right? And so each individual clinician, each individual medical director, each individual program is to take these recommendations and implement them in a way that is best suited for their program, which receives or which achieves the best outcome for your patients. And I think that is a really key point. And that is another big topic that they touch on in the second of the two that we're going to talk about today, which is is the Prehospital Airway Management Training and Education, National Association of EMS Physicians Position Statement and Resource Document, right? And that's the other thing is they really do provide some good documentation and sources for their information or for their recommendations in here. So I just wanted to kind of touch on a few things in here that kind of stood out to me. Obviously, there is a ton of information in here that we should all focus on. And you should absolutely go through and download and read all of these position statements. If you do not subscribe to the Prehospital Emergency Care Journal, I highly recommend you do it. If you are a member of the National Association for EMS Educators or the National Association, NREMT, there's a whole slew of agencies that if you are a member of, you can get a discounted rate for the journal. But the great thing is with this particular issue is that it's all open source right now. So here we go. Kind of introduce a whole bunch of stuff, principles of airway management education. So here in the introduction, defining competencies in airway management. This, the whole article is awesome. Couple things. You really kind of need to think about your practice and your agency and put it into context, because in this paper what they talk about is that the acquisition of skills is no longer adequate, and they break it into the three cognitive domains. There's the psychomotor, there's the cognitive, and then there's the affective, right? So do you have the skills capable of performing, or do you have the ability to actually perform the skill of airway management? Do you have the mental flexibility to apply your skills to the situation or the scenario, the patient scenario appropriately? And then do you have the affective maturity to look at it and go, well, okay, I know what this going on in this scenario is. I have the skills to do it, but is that in the best interest of the patient? And a prime example of that is these trauma airways. We know that these trauma patients need to get to a trauma facility. These crashing trauma patients. We might have the skills to do an intubation. We might have the ability to apply our skills to this trauma airway, right? Whether it's intubating upside down in a ditch, blindfolded, backwards doing the tomahawk maneuver, right? Whatever that happens to be, but recognizing that, wait a minute, and having the maturity to say, that's not what's in the best interest of the patient right now. I'm going to drop a supraglottic airway in, and we're going to get the heck out of here and get the patient where they really need to be. I'll tell you, when I first started out in, not when I first started out, when video laryngoscopes first kind of started to make their way, into the mainstream. I was working in the fire department, and I had my EMT partner. I was like, "Hey, what's that thing?" Right? We were demoing one of the video laryngoscopes, and I kind of explained it to her, and I actually put it in her hands. I said, "Try to intubate this patient," and in about 20 seconds, she had a tube in the patient, through the mannequin's glottis. And I thought, oh my goodness, like airway management just became a BLS skill. We know that's now not true because it is much more complicated than just simply being able to perform the psychomotor skill of passing, putting a blade into somebody's mouth and passing the endotracheal tube between their vocal cords. We now know that there's a lot more to that. But there was a there was a window of time where I bucked the notion of using video laryngoscopes because I thought, wait a minute, no, a hallmark of being a paramedic is being able to do advanced airway management, and I didn't want to give that up, right? Obviously, now we all mature, we grow in our practice, and if you're not always growing and learning and wanting to advance your skills, then it's time to get out of the business. But I learned, I grew, and now I am a stark proponent of video laryngoscopy with gum elastic bougie. I use it every single time. Doesn't matter if it's a difficult airway or not. Why? Because I want to make sure that when I have that difficult patient or that difficult airway, I am very skilled with that technique or with that tool, right? And so that's really what they talk about is we have to move beyond gaining skill and start to develop these other domains of expertise that will allow us to apply that skill appropriately, right? The other point that they kind of touch on here in a little bit, but it really kind of triggers something in my mind, is this idea of education versus training, right? We all talk about education and how we need more education, but I want to know how much of you actually have a lot of airway training, right? It's easy to sit in a classroom and have somebody talk to you about the difficult air, from the difficult airway course, which let me just say, I think that is a fantastic class. I love the difficult airway program. I've been through it multiple times. But beyond that, we need in-depth, challenging, hands-on training. And I suspect that most of you out there are doing that, right? You're getting into the airway lab and actually working through scenarios. That is where we are really going to develop our skill. They go on in this position paper to talk about the way we are training, right? And they mention this this concept here of deliberate practice, right? That is, they talk about sorry about that. They talk about deliberate practice, right? And if you've never heard that term before, it might be a little foreign to you, but deliberate practice is the process by which you go into the lab and you focus on a specific portion of a skill. It might be not advancing the laryngoscope blade too deeply, holding, for new intubators, it might be holding the blade the correct way. It may be sweeping the tongue, but you're doing these micro skills and you're practicing them over and over with the intention of mastering that micro skill and achieving a very specific goal outcome, right? And I'm not saying that you are doing that micro skill the same way in the same scenario, but you are focusing on that one particular skill. Now, the key to really really effective learning is to apply or to practice that one micro skill in various settings, right? So you're going to practice it, with a patient sitting in a chair, with a patient laying down or a mannequin laying down, in the dark, with flashing lights, inside, outside, with a partner, without a partner, whatever it is, with a pediatric patient, with an obese patient, with a pregnant patient, whatever it is, you're taking that one micro skill and you are practicing it to perfection. The goal here is this deliberate practice is you need to have a very specific outcome, and the goal is to constantly make that skill more and more and more challenging, right? Case in point, when we do airway management training, um, I will start off with a video laryngoscope, normal patient, laying down, super easy, and then I'll, and all I'm doing is I'm just practicing taking the blade and putting it into their mouth and advancing the tube to the level of the cords, right? That's the skill. It's kind of a two-step process. Then I'll take that same patient and I will turn them upside down, and I'll put them in a chair. Then I'll put them underneath a table. Then I'll turn the lights off. Then I'll, and then what I'll do is I'll take the bulb out of the laryngoscope, or I will, not turn the video laryngoscope on, and so I don't have the light, right, to simulate, a device failure, right? So I've got a lip mic on my helmet, right? So I'll put my helmet on. I'll do it under, the white light, and then I'll switch over to the green light on my lip mic. If you're not familiar with lip mic, lip light, mic light, whatever it's called, it's a little light that attaches to the boom mic on my helmet. And then I'll simulate a total failure of my boom light or lip light, as it's called. And I'll then have to pull out my pen light from my pocket and hold that in such a way that I can intubate. What I'm doing is I'm practicing this one micro skill with escalating levels of difficulty so that in the event I find myself in a situation where I have to perform this skill under challenging circumstances, I've got the practice, I've got the muscle memory. It's not foreign, it doesn't surprise me. And that's what they really emphasize. If you look down here, they actually have this graph here. Let's see if I can display it in full size. This is competency and experience, right? And they talk about down here everyday skills and deliberate practice. So if you are just simply doing the same skill that you would do every single day over and over and over, but you do it, for 10 years, your competency is not necessarily going to improve. But if you are focusing on deliberate practice, these micro skills, thanks for the thumbs up. If you're focusing on these micro skills, then you will see that your competency improves exponentially, far greater than that person who's not actually taking the opportunity to solve new problems and challenge themselves. So make sure that when you're going into the lab, whatever you're working on, go in with an intention. Not I'm just gonna get all my quarterly airways out of the way, but I'm actually going to take the time to take this piece of equipment and I'm going to figure out how I can challenge myself and make it harder for me so that my practice, my clinical skills improve. They talk about, like I said, the three key domains of learning. So psychomotor, cognitive, and affective. And then they actually go through and they kind of break down some specific um, um, recommendations within each of these particular domains. And I think it's really, really beneficial that they did this, right? So with the psychomotor, they talk about the deliberate practice, focus of instruction must be to improve some aspect of performance for a well-defined task, right? So the well-defined task is airway management. The well-defined task may be um, bougie intubated airway or bougie assisted airway management, or it could be placement of a supraglottic airway, right? So you have this very defined task, and now you're going to actually use or focus on a micro skill of that defined task. Awesome, Chris. Glad to see you here too. Yes, deliberate practice is where it is at, and that is how we as providers are going to really get better in our practice. What else do they do? We need to push EMS clinicians to exceed their current level of performance by targeting their zones of proximal development. I love that term, right? The whole concept is, we can go into the lab and we have a tendency to just do the procedures, right? We just pick up the blade, put it in the mouth, place the tube, maybe you inflate it. You probably don't. You probably don't even secure it. You don't even go through the mental process of, okay, this is how I'm going to draw up my paralytics. This is how I'm going to draw up my pre-intubation sedation, my post-intubation sedation, right? We just grab the blade, check our cuff, put the tube in, we call it done. But what we need to be doing is we need to be pushing ourselves to that, what do they call it, the zone of proximal development, right? That is that upper edge of our comfort zone, right? We need to be pushing ourselves just to that edge. We don't want to be pushed so far, and this really goes for those new clinicians. We cannot be challenged beyond our ability to comprehend and to advance, because then what happens is we just fall apart. But we need to be pushed to the edge of our comfort zone so that we are learning to grow, right? What do they say? If you need to get comfortable with being uncomfortable, right? When you are comfortable being uncomfortable and you are pushing yourselves to that level, to that edge of your comfort zone, now you are starting to actually learn and grow and become a better clinician. Um, right? We can go in and we can, like I said, I already mentioned proper placement of the blade in the mouth. If you have the ability to use a video laryngoscopy, and if you have had the opportunity to trial, half a dozen different types of video laryngoscopy blades out there or devices out there, that every single one of them is a little bit different. The King Vision, the McGrath, the Glide Scope, the CMAC, they're all a little bit different. And so if you just practice with one and now all of a sudden you pick up another one, you're probably going to have a difficult time because they are a little bit different. So picking up that device and learning how to use your device, and then learning how to adjust with that device, right? People will say, oh, well, if you're using a Mac blade, that Mac blade goes into Vallecula. But if you really know how to use that tool and you can't visualize the Vallecula, you can still use a Mac blade in order to get underneath the epiglottis and lift it, right? Totally agree with you, Chris. The true learning really does start when we are uncomfortable, right? Otherwise, it's just the mundane practice. We're not growing. Totally agree with you. Couldn't agree more. What else do they talk about? Yes, but making sure we're doing it absolute fear. I think what you mean is, like, don't push people to the point where they are so terrified of of what they're doing or what you're asking them to do that the learning stops, that the learning breaks down. Right? As educators, as senior members, people who have been in this job, and Chris, I know you've been doing this, even longer than I have. I know, or I believe, um, that we have a responsibility to mentor, to coach, to bring those people up who are, you know, who are just entering the field, just entering EMS, and it's a pretty exciting time. And I love learning from new providers because they learn things in paramedic school that I never even heard of. Right? Anyway. The point is that we can learn so much from new providers, but we also have a responsibility to take our experience and our knowledge and share that and can expedite that learning curve, right? So totally agree. Um, Domain, develop clinical judgment and higher order decision making, right? This is tremendous. If you are somebody who is wanting to get into critical care medicine, or you are preparing for or have already taken any of your board certification exams, like the FPC, CCPC, tactical paramedic, any of those, community paramedic now, I think they even have like there's so many different ones. You understand this concept of higher order decision making or higher order thinking. And this is that ability to, to think outside the box and apply the skills that you have, excuse me, the knowledge that you have in new and novel ways that you can then be flexible and can adapt to an ever-changing environment in critical care medicine or pre-hospital care medicine, right? So being able to actually adapt and learn to focus and adjust and accommodate and move on the fly and just be very adaptable. And I love that they really kind of focus on that 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 area as well when it comes to airway management. Um, and then, this is really cool here too. Patient outcomes should be valued over performance of individual airway skills. I'm not going to call anybody out, but I will tell you that in my career, there's this one experience that always stands out to me, um, and I learned a lot from this experience, and I hope this individual did too. It was a horrible trauma airway, and this individual felt like the most crucial thing to do was to place an endotracheal tube in the patient's airway to the point that the patient was peri-arrest. And not patting myself on the back, but I, at that time, had the clinical judgment and the mental fortitude and flexibility to say, placing an endotracheal tube is not what this patient needs right now. Drop the supraglottic airway, reoxygenated the patient, heart rate came back up, and we transported the patient to the trauma center with a king tube in place. That's what the patient needed. The patient outcome required airway management. The patient did not require an endotracheal tube placed. We did not need to perform the individual skill of intubation. We needed to take care of the patient. And I think when we can get beyond this concept of performing skills and realize that what we are doing is we are performing, we are applying our knowledge and our skills for the patients, not to the patient. And I think that that's a big shift. I heard that probably a decade ago, and it really did stick with me. That what we do needs to be done for the patient, not to the patient. Right? We are managing their airway for the best interest of the patient, not because we want to perform skills. Now, I'm not going to say that there haven't been times early on in my career where, sometimes we did things to patients because we needed practice. I'm not advocating that. I'm not saying that is right. It's not wrong, indifferent. We need to move beyond that. We need to realize that we are taking care of people. And the National Association for EMS Physicians kind of, probably unintentionally, but they make that a priority in their statement. I love it. You must overcome the technical imperative. Awesome. Perfect. They also go on to talk about credentialing and continuing education. Yes, we all know that credentialing, is a good thing. Um, I'll be honest, I haven't had an opportunity actually to really delve into this particular section. I don't really know what they're referring to as far as credentialing for Airway. I'm credentialing and continuing education are essential to the development and maintenance of high quality care as an EMS clinician. And I don't know if they're talking about credentialing at the local level, or if they're actually talking about like board certification credentialing. I got to get back in and actually read this a little bit in more depth just to understand exactly what they're referring to. But, you know, if you have the opportunity to take one of these focused, targeted airway management classes, like the Difficult Airway course, there's a number of other airway management classes out there. I highly recommend it. It's good to get a different perspective from other educators and really have that opportunity to focus on that one skill. And they really do talk about that kind of as a general theme throughout the entire um, publication, if you will, all these position statements. So, anyways, that's what I have for today. I hope that you will come back and you will join me. I'm going to be doing a broadcast like this once, maybe even twice per week. Mondays, Tuesdays, and Thursdays are going to be the days that I'll be doing my broadcast. It's probably going to be Mondays and Thursdays. I really want to get on a regular schedule here so that you can anticipate when these broadcasts will be. Obviously, everybody's got different schedules. I have different schedules. It seems to be changing more and more these days with COVID affecting staffing levels and all that. But nonetheless, um, this is going to be a regular thing. We've got 18 articles, individual position statements to get through. Um, and I really hope that I will see you back here later. Maybe what's today? Wednesday. I might even do another one on Thursday tomorrow, just for the fun of it. So please join. Here we go. I'm still working out some of these little new fun features that I have here. Like this has got my name. This is the website, flickrit.com/the medic lab, where you can learn more about the medic lab. But also, these broadcasts are going to go out here in the medic lab group on Facebook, as well as to a Facebook channel, not a Facebook channel, a YouTube channel that we are starting up called the medic lab as well. I'm going to be using Facebook still, but I kind of want to get off Facebook because I'm not really liking some of the things that they're doing. But if you would be so kind to head over to YouTube, do a search for the Medic Lab, and follow that channel, subscribe to that channel. I would really appreciate it. I've got this really cool. Here we go. Here we go. There we go. Head over to YouTube, subscribe, thumbs up, do the bell thing. And as we publish more content, it's going to show up there. I'm going to be doing more live broadcasts there as well. I would really love to kind of see you over there. Thanks so much, everybody. These will also be saved, and they'll be published in the Medic Lab, our training portal for you to go back and review later on if you'd like. So, Chris and everyone else, thank you so much. If you have comments, leave them down below, and I will catch you next time. See you, everyone.